e-health initiatives at the Faculty of Medicine. Prof. CJ will talk about Cosmos, a digital platform which, as I understand, was developed and deployed in lightning speed to cope with the increasing number of individuals in home quarantine requiring close COVID symptom monitoring. CJ, please go ahead.
Thanks very much, Rina. Can you see the screen, Rina?
Yes, I can.
Great. Thanks again for really inviting me to share this work that not myself, but the whole team has done to try to tackle this problem of monitoring COVID patients, not patients actually, patients under investigations. And then we seized the opportunity to solve a real world problem at that time, a really urgently needed solution. So I'm just going to go through this with you in about the next 15 minutes or so, is that we know that the focus has always been at the initial phase of the COVID pandemic is on the patients that admitted to the hospital. How do we cope with them? And we are really worried about how these patients are being managed in the hospital as we are struggling to understand the disease better. But at the same time, more in the outpatients and the community, there's a group of people who are exposed to patients with a COVID infection who need to be monitored at home. And if they develop symptoms early, then they should come quickly to the hospital to manage their disease. So at that time, I think the task is fall on the MOH, health district health officers and staff to call the patients under investigations on a daily basis to check on their symptoms and advise them accordingly. So this is a huge task because they'll spend their time calling them, trying to screen through their questions, and then trying to see whether they need to come to the hospital. And for every positive COVID patients diagnosed, actually there needs to be about 16 suspected COVID-19 patients that need to be taken care of. And this is a huge task if you multiply by the number. I think at the first phase of COVID, it was still perhaps copable, but imagine now with this exponential rise in COVID cases, this is a huge task for the Ministry of Health district officers to monitor. And also, due to the lack of resources, some of these PUIs were not very well monitored, as you can imagine, the overwhelming workload. And many of these PUIs then present to the outpatient department of UMMC, RUCA we call it, or in the emergency department with symptoms which have worsened, or some of them come without having any sort of much delay in presenting because of the fact that they were not properly monitored. It's with this in mind that in March, a team of us came together to try to tackle this solution. This is the solution, digital health solutions called Cosmos, which is an automated system to monitor patients with suspected COVID-19 at home. So basically it consists of two really systems. One is the chatbot, which we use Telegram, which is an interactive system whereby we can have a chat with the patients in their home and using an automation chatbot. And remotely, doctors, nurses, or the district officers can monitor the symptoms at home, in the office with on the dashboard, at a glance. So basically, Cosmos is really the COVID symptom monitoring system that comprises of an assessment board, which patient uses. It also pushes through education materials to the patients. And thirdly, it allows some form of communications with the patients, with the doctors. So this is really what we call the storyboard of Cosmos. So just take you behind how it flows through. First, the doctors screen the patients when they arrived in the hospital or in the clinic or in the emergency department. Those with suspected COVID patients will see the doctor. If they're severe with respiratory symptoms, they will be admitted. If they're asymptomatic or very mild symptoms, then the doctor will register the patients on the Cosmos dashboard. So this is not a system and applications that patients can download and use at home, but they need to be registered because they need to be monitored using the dashboard. So the doctor will also ask the patients to install the Telegram and activate the Cosmos, and patients after which can go home. After which, as you know, the PUI will need to be monitored for about 14 days. It's through this chatbot that every day the patients will be reminded to use the chatbot. Automated is all reminders are used using the interface to try to remind them to fill in the symptom checklist. So with this, there are multiple patients, many patients here using the chatbot, reminded, and then they will then report their symptoms to the dashboard, which the doctor, the healthcare workers will monitor the database on a daily basis. So the patients actually will be reminded twice before 2 o'clock. If by 2 o'clock they have not reported the symptoms, then the doctor or the healthcare workers will call them to find out what's happening. So after that, the patients then will be advised to go to the hospital to see the doctor if they have symptoms or there's deterioration of the symptoms, or if they're well and the symptoms has not deteriorated, then they can stay at home and continue to use the Cosmos applications until 14 days. So basically, Cosmos is a chatbot that uses Telegram that automatically assesses the symptoms and is able to provide advice. It's almost like a decision support system that alert the doctors when the symptoms worsen. The Cosmos dashboard is used by healthcare workers, which is able to filter stable patients for the doctors and focusing really on the symptomatic patients. Preliminary study data found that it reduces 90% of the workload of the healthcare workers, at the same time ensuring that patients are monitored safely at home. So we developed this quick run through is that there are 3 phases to this. The first phase, what we did was that we did an iterative agile development process and launched it within 19 days. In phase 2, the implementation feasibility study was done in RUCA and Emergency Department UMMC to ensure that the system is robust, is valid, and it is reliable, because patient safety is at stake if the system were to fail. And in phase 3, we then implemented in the PKD, the Health District Office, where the real needs are. So just to show you that this is the multiple Zoom meetings we had, we almost nightly meetings with our colleagues from Faculty of Computer Science and IT. These are true collaborations, interdisciplinary collaborations between FOM, UMMC, as well as the colleagues and students from the Faculty of Computer Science and IT. Some of the students from the Faculty of Computer Science and IT have graduated. They work in China, in Australia, in Singapore. They all come together to support us and help us to build this within 19 days. Of course, we also have our colleagues from ID, from ED, and of course, RUCA, who come on board very quickly to support this development process. So preliminary evaluations in phase 2 found that most of the users were very happy with the system. The system enabled the doctor to monitor me closely on a daily basis. We did individual interviews. I used to type, and then there will be instant feedback. So in that sense, that you feel reassured that I'm not alone. Unlike the card 1/3, the doctors will only see it after 14 days. Yeah, so it's very simple, it's very easy to use, and the reminders are all there. So the other thing is that it reduces healthcare burden substantially. Cosmos actually found to reduce 80%, almost 90% of the doctor's workload in monitoring patients with suspected COVID-19 infection based on the data we collected in June. In phase 3, where we rolled it out to the PKD, so 990 patients were registered with the Cosmos at that phase. 3,000 daily reports were submitted to the Cosmos PKD dashboard, and 193 daily reports need teleconsultation. So what does this mean? This means that only 6.4% of the cases who really need attention were called after the assessment by Cosmos, a drastic reduction of more than 90% when we implemented in the real world. So the title says beyond. So what's beyond really this Cosmos? Actually, Cosmos is just a system. It's a symptom monitoring system, but applied in the COVID context. But as you can imagine, this kind of system is very flexible, and it can be used to monitor many other diseases like mental health. And currently, we're also exploring the options of monitoring chronic diseases like diabetes, because we know that there are potential collateral damage if we do not look after our patients with chronic disease, because all attention has been focused on COVID-19 infection. So this is what Cosmos can do beyond the pandemic. So this, I must acknowledge that this particular study is being funded by the University of Malaya COVID-19 Implementation Research Grants, who gave us the tremendous financial support to make this possible. Thank you. Thank you very much. Rena, you're muted, Rena.
Thank you, CJ. In the interest of time, we'll move on to the next speaker, and hopefully, CJ, you can stay on to field questions after all of our speakers have finished the presentation. So our next speaker is Ms. Chong Ming Lee, a counseling psychologist in UMMC, with a strong interest in HIV and mental health. Her roles as a psychologist and researcher provides valuable insights into developing holistic care models for her clients. Her talk today will be on using digital solutions for HIV prevention and how, and how the experience of COVID has helped shape this model of service delivery in Malaysia. Please go ahead, Ming Lee.
Can you hear me clear?
Yes, I can hear you.
Okay, you see my slide?
Yes.
Okay, thanks, Rina. It's my honor to present with two distinguished and well-respected researchers, Prof. Wu and Prof. CJ. And in my presentation, I will bring you through a digital solution for HIV prevention, the PrEP Myself program. So I'm a psychologist in the HIV clinic in UMC. When I first started in 2012, our HIV positive client would bring their HIV negative partner to see us. And when we have to try our best to assist the partner to stay negative and also to ensure that they have a healthy and fulfilling life together. The HIV prevention method that we mostly talk about were condoms, frequent HIV testing, and also taking HIV treatment. Because by reducing the amount of virus in the body, people living with HIV cannot pass the virus to others. So in 2013, we started to prescribe PrEP to these HIV negative partners. PrEP, or is also known as pre-exposure prophylaxis for HIV, is a pill that a HIV negative person can take daily to prevent HIV infection. And a few years down the line to now in our HIV clinic, we are seeing more and more key population at risk are coming forward for PrEP, regardless of their HIV, of their partner status, because they want to take charge of their own health. So although there are a number of private clinics that are also prescribing PrEP, we find ourselves burdened with more and more people coming to us for PrEP. And one of the reasons of this is that the public have no idea which private clinics do provide PrEP. And if the person is lucky and found a clinic that provides PrEP, the cost is the next issue, because some private clinics were trying to make a high profit margin from the PrEP service. The highest selling price for a bottle of PrEP that we know of was about 800 ringgit as opposed to 35 ringgit at UMC. But some clients will still try their very best to save up to pay for that PrEP because they think they have no other options. And being in a society that is still fairly conservative in our cultural and religious practices, there are still a lot of stigma and discrimination against certain sexual preferences and behavior. During the consultation with healthcare providers for PrEP, sexual history and behavior has to be asked. This can be an awkward 2 to 3 minutes, but I'm sure it feels like a lifetime for some client, especially if the healthcare worker are not sensitive and it makes the client feel judged. So in the effort of increasing the provision of PrEP and also knowledge at the community level about PrEP, in January 2019, with funding from WHO and inspiration from PrEP Locator in the United States, we created the My PrEP Locator, which is an online directory of clinics that is providing PrEP in Malaysia. So to cater for a multiracial society in Malaysia, we have a few languages options. And if you can see from this screenshot of the PrEP Locator, if I search under Petaling Jaya, and it will direct me to the provider that is nearest to the area. And some clinic information such as the operation hour, the contact number, the address, or even more detailed information such as whether the patients need a referral letter or if they can walk in are also provided in the PrEP Locator. So what makes us different from other healthcare listing online is that there are some training requirements that we need the provider to fulfill to ensure that providers are trained and equipped to provide PrEP. When the provider requests to be listed in the PrEP Locator, they will be directed to HIV Connect program. Is an online learning program that is held in collaboration with Malaysian Society for HIV Medicine, MASHIP, and the Malaysian AIDS Foundation. The HIV Connect module is divided into 3 phases. There are online module that is compulsory and providers is required to complete the PrEP and PEP module to be listed in the PrEP Locator. After completing the module, practitioner can choose to attend a face-to-face workshop and proceed to a short clinical attachment program at selected HIV clinic, and we are proud that UMC are one of the selected sites to provide clinical experience to this general practitioner. Of the 25 PrEP provider listed so far, majority were private clinic or hospital, and 21 of them being general practitioner-led center. As you can see from the map here, these providers are mainly located at the urban area in Malaysia. And now I will show you the estimative data from Google Analytics, the data analysis tool that we started using since June 2019, as we do not collect self-reported data from user. From June 2019 to last month, in the duration of 18 months, we have about 5,500 users visited the website. And from this diagram, it's telling us that we are reaching a high number of new users while maintaining about 13% of existing or returning user. And 45% of these users came from the locator when they were searching for keywords like PrEP in Malaysia or HIV prevention in Malaysia. And 29% of them came from referral from social media such as Twitter, Facebook, or Instagram. So let's take a closer look on the trend of user on the locator. And I will bring your attention to the 29% of the social media referral. In the diagram at the bottom shows the trend of number of users who visited the locator in the past 18 months. And when there were Twitter, Facebook, or Instagram posts by social influencer, or what is now known as KOL, key opinion leaders in the community, we observed sudden spikes of user in the website. So this diagram on the right side show the distribution of age group. Majority of the user aged between 18 to 34, sorry. And on our findings on gender of user who access PrEP Locator, it was surprising that we have 45% of the user being female. As we know, the key population at risk that are most likely to take PrEP as a prevention method are men who have sex with men. Some of the reason that we could think of when we try to make sense of the demographic data is that Google was using the impression based on user Google account, the previous search on your Google browser, and the website that the user visited. So we have to bear in mind that this demographic data is not 100% accurate, and it is the estimative data from the user Google account. And most of the users are from Malaysia, and we have about 16% of users from Indonesia, 5% of users from United States. And we think that the user from Indonesia and overseas, they are reading about information about PrEP rather than looking for a provider in Malaysia. And most of the users access the locator using their mobile phone. So we had to make sure our locator is mobile interface friendly. So when the PrEP Locator seemed to be effective digital health tool that reached the community quite well, COVID-19 pandemic has highlighted a gap between the locator and the healthcare on the ground. During the COVID-19 lockdown, I met a client in our HIV clinic. So he just got tested positive for HIV and he shared his journey with me. So this man was from KL and he went to Penang for work about 5 years ago. He was taking PrEP from a clinic in Penang for the past 2 years on a 3-monthly follow-up. In March 2020, he came back to KL for a short work trip and also to visit his parents. And he was supposed to return to Penang to continue his routine life there. It is also during that time that he was stuck in KL because Malaysia went into a lockdown due to the COVID-19 pandemic. So he was unable to travel back to Penang because of the interstate traveling ban. So he continued to work from home in KL for months, living with his parents, life goes as usual. And a few months into the lockdown, he ran out of his PrEP medication. Although he still has substantial risk for getting HIV, he had to stop taking PrEP for a few reasons. He didn't have any of his medical record with him, including the blood test result for his PrEP intake before, because he didn't really see the need to have them because he thought he could always go back to the clinic that he went in Penang. And it was also difficult for him to open up his sexual history and risky behavior to the healthcare provider that he first met in a new clinic. He didn't feel comfortable to be honest to the healthcare provider because he felt that he was judged based on his sexuality. In the end, he was not prescribed PrEP. So some of the lessons learned from our data and client experience are the linkage to healthcare providers from the locator needs to be improved. Although we have a few online medical video consultation platforms available like Get a Dog, the people who are providing this service are often not HIV sensitive and they are not well educated about HIV. So these platforms tend not to appeal to the key population at risk. Developing a platform that took into account of this sensitivity is very important. It is important for the client to be empowered by taking note of their own medical record. This medical record will ease the transition or referral to a new healthcare provider in order to continue the care that they needed. Also, by having their own medical record, it helps the client to take ownership of their own health and care. So stigma in health facility undermines the delivery of quality healthcare. It is an important issue to be addressed, but it will take a long time to address this issue completely. So small little step that we can take to reduce the stigma experienced by patient is getting the patient to fill out a pre-filled consultation form that will talk about sexual history or other screening, that it helps the provider to get more accurate history and client feel more comfortable telling the truth. So from the lesson learned, the next step is to how to improve the PrEP locator to a more holistic digital health solution. So we came up with this proposed program called PrEP Myself, where we create a pathway for clients from the website to the providers. First, users have to create an account in the My PrEP Locator. Before the user book an appointment with the doctor, user can make use of the sexual risk assessment form to assess their own sexual risk and decide if they should go on PrEP or not. If they decided that they would like to go on PrEP, they can then choose their preferred clinic based on the location or rating or feedback from other users. After scheduling an appointment, the client will then fill up a pre-consultation form, which includes sexual history, mental health, and substance screening, as they are highly related to risky behavior of the individual. Providing sexual history by filling up the form helps to address the stigma issue and discomfort experience, as opposed it was done face-to-face. It also helps to improve the accuracy of the sexual history as it is done at the comfort of the person. So for mental health and substance use screening, client can either choose to speak to the healthcare provider about their result or explore on some self-help strategy or resources that is available in the locator. In order to equip healthcare provider with skills to address mental health and substance use issue, an online module focusing on interpersonal counseling and brief intervention will be developed and incorporated into the HIV training program. On the day of appointment, client will go to the clinic and scan the QR code available at the counter to record the attendance. Healthcare provider will then receive a pre-consultation form that the client fill up before he or she call the patient in. Upon scanning the QR code, client can also choose to share his medical record to the providers if it's a new clinic. So there will be a medical history profile that user can make use of to record their tests systematically to help the transition to other healthcare setting or for any reasons. And it is also important that client has full access of their medical record, and it is up to the client whether they want to share it with healthcare worker. In the planning of this program, we'll be engaging with the relevant parties to ensure that we are complying to the Personal Data Protection Act. A point reward system will be introduced to reward client based on the various activity they engage in the PrEP locator, such as making appointments and be present for the appointment, writing a review for the visit and service, or even referring a patient. And it will be a forum where user can provide feedback of their experience with providers. We hope that by hearing the voices and feedback, we can empower the community at risk. And from the provider perspective, this feedback can be used to improve their service. In the end, this program aims to link user from the My PrEP Locator to getting their PrEP medication. So last but not least, an important features that we propose in real-time monitoring system for researcher, and it helps to evaluate the program real-time and help to guide strategy to increase PrEP uptake in the key population at risk and improve PrEP provision in Malaysia. So this is my last slide from where we are now to the next upgrade of the locator. Overall, we have learned that we should focus on evidence and need-based strategy to drive the next upgrade of the locator by having self-reported data from user rather than Google Analytics. We can streamline our service and strategy for improvement. And lesson from the referral from social influencer, we should leverage on the social media to increase the publicity of the locator. And also in the process of planning the structure and the process of linkage to PrEP provider, we will engage stakeholders to get their opinions and input. These stakeholders include people who is currently on PrEP or people who wish to be on PrEP, and also the healthcare provider who are sensitive to the need of community at risk, and of course, also the healthcare worker who are not sensitive as well, because we're going to listen the story from the both sides. So this is the end of my presentation, and thank you for your attention.
Thank you very much, Ming Li. That was a really great talk and a really important service for us to address. Our next speaker is Professor Wu Yinling, who's a consultant gynae-oncologist in UMMC and the founder of Rose Foundation, an NGO that's dedicated to the cause of eliminating cervical cancer in Malaysia. She will talk today on the Rose solution and how it has made cervical cancer screening more accessible and affordable for the P40 community. Over to you, Prof. Wu.
Rina, can you see my slides and can you hear me?
Yes, I can see and hear you. Please go ahead.
Okay. So I'm going to share with everyone here a little bit about Rose and how we had the agility to adapt it during the era of COVID and thereafter. Just so for your information, this year, the World Health Organization launched a global strategy to eliminate cervical cancer. And Malaysia adopted this strategy so that we can end this, the scourge of this cancer by 2030. Now, what do we have to do to ensure that we can eliminate cervical cancer? This is what we have signed up to. So we have to reach 90% vaccination rates with HPV of all 15-year-old girls by 2030. We're on par for that.
Sorry, you know, your slides are not changing.
Right. I think it's a bit slow.
Okay.
Can you see it now?
You're still on, you're not on presenter mode yet. Could you click on slide 3?
Can you see the change?
No.
Okay, let's see.
Yeah, we see that now, and
You see the presenter mode.
yes. Yeah.
Better?
Yeah.
Right. So what do we have to do to achieve cervical cancer elimination in Malaysia by 2030? 90% of our young girls need to be vaccinated by then. 70% of our eligible women need to be screened with a high precision test twice in their lifetime at the age of 35 and 45. And 90% of women with abnormal screening need to receive treatment and care. So in terms of real world success globally, many countries have achieved their outcomes, favorable outcomes, even to the point of decreasing the incidence of cervical cancer in countries such as Sweden, Finland, and certain states in America. Many of these countries have also converted from traditional pap smear to HPV testing. Now, if we were to achieve effect of cervical cancer to upper middle and lower middle income countries such as Malaysia, and this is very important. And while the world was trying to make provisions to achieve this target, COVID-19 hit us. So if we were to adopt these effective strategies in countries like Malaysia, we really have to come up with a different type of health system that works for us. We need a new set of approaches that is developed for our local setting. We can use the expertise of countries from high-income countries, but there needs to be a process of co-development and mutual learning. There must not be an imposition of strategies that work in high-income country to our country. So organized cervical screening is such a program that can be considered as one of these programs that have not been successful in lower income setting. And therefore, the global elimination strategy set out by WHO provides us with the opportunity to innovate and to expedite cervical cancer elimination in our setting. So what is the ROSE solution? The ROSE solution really has three components to it. Instead of the conventional pap smear, which requires a speculum examination, women can now perform their own self-swab. Instead of looking for abnormal cells under a slide, a molecular test called HPV testing can be performed. And the third component, which I want to talk about, is the e-digital and mobile platform that really enables us to undertake the entire process of screening and follow-up. So I think very similar to the previous two speakers, Program ROSE really utilizes the principles of design thinking, where you start with the patient first, a human-centered approach in developing strategies. It's not about the test, but it is ensuring that the test, women who have the test can be monitored and followed up. Now, in a situation like you use, it needs to be agile with the situation, the global situation, such as a pandemic. So collaborative partnerships are extremely important. For ROSE, we have really been on the ground with our partners, with the grassroots, with the patients, and we identified what are the solutions that will work for them. So this has been a very long process, but I think it has borne some fruit. So we looked at what happens to the women, where she goes to, where are the areas where she might fall off the screening pathway in terms of follow-up. Now, I want to talk about the mobile phone. Originally, we were going to adopt desktops or laptops. And we have partners, I hope they're here on this phone call, such who have experience previously with rolling out solutions. They said that you cannot afford to buy new equipment for Klinik Kesihatan. And therefore, we had to develop a front end on a mobile phone. Now, is Malaysia ready to use mobile platforms for health strategy? I want to share this with you, a statement by Melinda Gates. Back in 2018, when they came up with the annual report, they shared what they didn't see coming in terms of lessons learned as a foundation. And what they call surprise number 9 is that mobile phones was most powerful in the hands of the poorest women. And I want to repeat this statement that she has made word for word verbatim. She says, for the world's most marginalized women, a mobile phone doesn't just make their own old life more convenient. It can help them build an entirely new life. That's because connectivity is a solution to marginalization. They're using them to change social norms and challenge the power structures that perpetuate gender inequality. And I think whether it's PrEP or whether it's cervical screening, we really need to use mobile technology to challenge these power structures so that it is more friendly to the user. Just some statistics in Malaysia. I was quite surprised with this. We have a population of 32 million, but we have a mobile subscription of 40 million, which means that each person has more than one mobile phone. And these are the internet usage and the social media use. Look at how much social media we use. And if you want more data, you can go to the MCMC website, or you can go to this Hootsuite social website. And the connections and the percentage of population is shown here once again. So I would say, and we have witnessed this, that mobile solutions are ripe to be used in countries like Malaysia. So how does ROSE work? During the pilot program, I walked into a Klinik Kesihatan. I registered myself on a paper, and a nurse then entered my data into the registry. I then received a message on my mobile phone, which then validates that my phone number was correct. She taught me how to perform a self-swab. I went behind a set of curtains. I performed the self-swab, and the results were out within a few days. So it only takes 9.5 minutes from the point of identifying the person who needs the test, registration, education, getting the test done, to putting the test into a box to be processed. That's how quick it is. So the beauty of the swab, and this is relevant if you want to reach the interior rural area, is that after the swab, this swab can be kept in room temperature for it to be brought back to a central lab. Now imagine if you have a mobile phone to register the women wherever you are, in whichever far-fetched place that doesn't have a healthcare facility, with a phone and the swab, you can really get a woman screened. And with this, with the advent of evidence-based screening using self-swab and HPV testing, Malaysia, the Ministry of Health has already made the commitment. The guidelines are there to transition from Pap smear to HPV testing in the next 3 years. So we have to remember this statement. Remember that screening does not prevent cancer. It is a pathway that needs to be followed through. So what happens to a woman with an abnormal screen? From our ROSE experience, 90% would attend follow-up. 2/3 of patients, when they receive their screening results, they would call up our call center and they would make their own appointment. So you can see that if they have the access to make their appointment, to schedule their appointment, women will not fall through the gaps of our follow-up. Also, for our experience, the ability to make contact with the tertiary center is extremely important. On average, 2 calls are required to establish contact. we will also need a number to call to reschedule the appointment for any reasons whatsoever. And in our experience, 1/3 of women required rescheduling. Now you imagine if they don't have the ability to reschedule, 34% will be considered lost of follow-up. So the feedback are these, but fast results on the phone are all reasons why women like this method. Setup is easy. We can move this screening in the community. You can see here, we can raise up tents, we can use banners as curtains. So the idea behind Rose is that screening can enable women to do this in the community away from the healthcare center. The training packages are there. So what we use to train healthcare professionals can be used to train community leaders. And this is exactly what we've done. We have gone to different areas to train the women leaders, and they carry out the registration, they educate, they do the screening themselves. So with the impact of COVID on health, there are certain things that we can do better. And we can also use technology to digitize healthcare. Healthcare facilities are stretched. What we can move out from tertiary centers, we should move. Healthcare professionals should be released from screening activities to cope with the current COVID situation. Vulnerable populations have increased. What was conventionally known as vulnerable, i.e. the poor, women, the people who don't have access to healthcare, this has become a larger group of population. And so we need a solution to now reach the vulnerable population. I'd like to put this challenge to you. We can flip the challenges of COVID to opportunities. Let's take the opportunity to move screening from tertiary to primary care. Diagnostic laboratories that have been built up or set up to use for COVID testing can be used for HPV testing. Digital technology used for contact tracing can now be used to complete the path of screening care, whether it be NCDs, hypertension, diabetes. It can be used then to ensure that patients complete their follow-up in a tertiary center. So World Health Organization has really recommended that we move to self-care interventions to ensure that women are not lost of follow-up in many aspects of reproductive health and NCD care. What is self-care? Self-care is defined as the ability of individuals, families, or communities to sort of look after themselves with or without the support of a healthcare provider. So I think mobile platforms, digital platforms really empower self-care strategies as highlighted by Meng Li earlier on and CJ to really take up their own care. Decentralizing to community helps, and it permits surveillance. I'd like to end my talk with that, and I'm happy to take any questions.
Thank you, Yinling. Thank you all the speakers for really fantastic talks and extremely inspiring. Now, if you have any questions, you can ask them directly to the speakers, or you can type them in the chat box, and I will help field them to the relevant speakers. Perhaps while we're waiting for some questions to come through, I can get the ball rolling. So we've got about 10 minutes. And I'd like to direct this to you, CJ, really mainly because you have really been a champion of e-health initiatives in the faculty for a long time. And what we've seen here today is case studies of really good digital solutions that have been developed by researchers that have a huge opportunity to be used in the public. And these are not all. I think we know of quite a number of solutions that have already been developed, but very often we see this funded, driven, and used more in the external, informal healthcare setting. How do we bring this to mainstream healthcare formal settings through Ministry of Health or Ministry of Education so that the wider public can actually benefit from this?
I think, Rina, it's absolutely good questions. Most of the time we develop this digital solutions and it's for research and then answers with publications or presentations. But really what we're looking at is really how to think about implementation when we develop such a tools. There's no point just doing it for the sake of doing it and end with evaluation. So this would mean that we must have an implementation plan in mind. This would mean engaging the key stakeholders when we develop all these digital solutions. For example, Ministry of Health, maybe the hospitals, even the private or the public sector. So I think for Cosmos as well, we tried to reach out to the Ministry of Health, the digital health leads, the family health divisions, the public health divisions, and to try to sort of tell them about these potential solutions. And then we start off with PKD Petaling, who is very kind to actually allow us to test it out with them to see how it is. So I think with these small successes, I think you build confidence. And then I think more likely that the key stakeholders like Ministry of Health will take it on. So I think it's bottom ups, it's also top down. I think both ways we can reach successful implementations of the solution. Can't hear you, Rina. I think you're muted. Yeah.
Sorry. Thank you, CJ. And I'm going to read out a question here. It's also directed to you. May I know how this digital technology has been accepted, utilized, and accessed by patients in the rural area?
Right, this is a tough one because we only pilot tested it in UMMC and PKD Petaling. That being said, I mean, that's the intention. In fact, when there's an outbreak in Sabah a few months ago, I think the Sabah colleagues actually contacted me to ask whether it's possible to use it in Sabah. But after much discussion, they find that it might be challenging because some of the patients or some of the people there in Sabah may not have maybe is the technology literacy or maybe access to internet and network that allow them to use it effectively. So if all this infrastructure is not in place, it might not be a good idea to implement it in such a setting. So because then, then there'll be breakdown in communications and then we think we're monitoring them, but they are not being monitored. So I think all this need to take into considerations when we implement such technology in the rural setting.
May I ask a question?
Yes, sure, Shamla, go ahead.
Hi, this is Shamla, and thank you so much for such amazing presentations from all of you. Back to the whole rural area and how the rollout be, because I think especially the mobile technologies reach out further, the further away you are from a central healthcare facility. I'm quite curious about the thought process or the design process that goes on how to train or how to deliver further, even just the usage of a mobile app into the rural areas.
Yinling, do you have some experience?
Yeah.
I think we had a lot of help. I don't think Wendy is on this call, but we had someone who helped us develop the app in such a way that it's simple. You don't have many buttons or many fields, so that you don't capture, because sometimes as researchers or academicians, you try and capture as much as possible. But the idea behind that is to make it very simple. Few fields, not more than 5 fields. So we've had quite a bit of success with that. The local women were able to register the patients. So Shamla, our app is to register the patients and to send SMS and all that to them. We don't provide information yet on the app, maybe unlike Meng Li or CJ's app, where it's also an educational platform.
Right. Meng Li, do you want to address that with regards to how would you deal with literacy, patient literacy, in terms of if you're providing educational material as well in your apps?
I guess when we first started the PrEP Locator, we only have it in English, and we realized that we are not reaching enough the community, because language was a barrier, and language should not be a barrier for information. So then we engage with translator to have it in different languages, and also we're exploring on a sign language. So sign language information is when is a video recording of a sign language translator. So is to have that message delivered to the marginalized population, right? So I think there's no one idea that fits all. Is how we then, when we have an issue, we think of one single way to just solve that little issue. And this process is a long journey.
Thanks, Mingli. I have one more question that's perhaps most relevant to the work that you're doing. How do you, and I suppose the rest as well, how secure is the information stores on the mobile? And with Mingli, I think in your solution that you presented, one of the aspects was, one of the key features of that was that the patient information, the patient records were within the patient's control, and they decided who then they wanted to share it with in terms of whichever healthcare provider they went to, which means it almost becomes like a small EMR, electronic medical record. So how do you deal with the issue of data security in this context?
So in the process of designing the app and the storage of data, we will be working with multiple parties from the legal and the IT department to hopefully to better inform us on the regulation on perhaps certain server that is mHealth secure. And I think that's something that the researcher us can do to protect the data. But I think what I want to say is also that although it might be an issue in providing the patients with their medical record, but we have to bear in mind that it is their own medical record that they feed into the system willingly. And of course, we will, so because we have not developed that program, so we have to really engage with the respective parties to get their input. I guess we as a researcher, we have to be reminded that we are not expert in everything that we do.
Thank you.
Ina,
Yes.
if I just add quickly, is that for Cosmos, it's not possible to do it the research way, because ideally we should get users' requirements and all that. But in the really tight time, we just cannot afford to do that, which is something I find struggle with, because I do it sort of like systematically. But in this case, I think we just have to jump into it and then quickly test it out and see, and then maybe just get quickly some friends, colleagues, just to look at it and just get a quick feedback and roll it out. So the safety, the accuracy, and the timeliness is very important in those situations, particularly in the COVID setting. So what is feasible in research may not be possible in the real world during the pandemic.
And I think we've learned a lot about that in the last year. So I have one more question that I'd like to direct perhaps to Mingli and Prof. Hu. CJ, you talked about having funding from the university to help kickstart Cosmos. How was it like for you, Prof. Hu and Mingli? Because as I understand, I think a lot of funding bodies in Malaysia don't really have dedicated funding for digital solutions. And it can be quite expensive if you have to engage IT expertise and so on. And we are at an intersection where we are building sort of pilot programs, but we don't want it to stay that way, and we want it to be more sustainable over the long period of time, and that's going to require some degree of investment. From your experience, where do you think this is going to come from?
So for Rose, really our success was through collaborations, and I don't think we didn't need to reinvent the wheel. So with a bit of help from crowdfunding and from individuals who shared in the vision, we managed to put some investment in to refine an existing platform that was already in use elsewhere. So for Rose, I'll just touch a little bit on it. We store our data in an encrypted fashion going up to the Microsoft Azure cloud. And it is PDPA compliant. And we also say that Rose does not own any of the data. The data belongs to the patient. I think anyone who does research and any service that we give, we need to really respect the sanctity of that, in that the data belongs to the individual and anyone who manages it does not own that data.
Okay, thank you. Meng Lee, any short answer to that? I know we sort of run out of time already in terms of funding.
Yeah, actually we have just put in an application to through Malaysian AIDS Council for a global fund, because I guess during this COVID time we have realized that there should not be boundaries, and everyone are looking into e-health as a solution, because we know that there's limitation to physical interaction, right? And another thing that I think is another way to go is from the community to the community. So in my work with the PrEP Locator, I have so much help from my PrEP user who volunteer their time and their input and their skills to develop the app, to translate. So they themselves feel happy to be contributing to their own community. So it's from the community to the community.
Okay. So thank you, everyone. Thank you to all the speakers for a fantastic and inspiring talk, and really for your passion in driving all of your cause. I think it was very evident from the platforms that you shared with us. And to the viewers, I think we've reached almost 75 people. Thank you for tuning in, and please tune in next year for our Science Café series, and please watch this space for our advertisements. Thank you, everyone. Have a good day.